Before I get started on today's lecture, I wanted to remind you that the final exam is coming up. It will be held on Wednesday, May 3rd, 2017, from 10 a.m. to 12:45 p.m. in RH 101. As with the other exams, if you arrive after the first student has left, you will not be able to finish the exam. This is a comprehensive exam. 100 points will be dedicated to the last 6 chapters, and the remaining 100 points will be spread out over the first chapters, 1 through 18. Only the chapters that we've covered in lecture, so you will not be tested on chapter 4 or any of the other chapters we didn't cover between 1 and 18. Today's lecture will focus on microbial diseases in the respiratory system. This is chapter 22 of your book. Today we'll be discussing the respiratory tract. I'll describe parts of the respiratory tract and how our body uses the respiratory tract to keep microbial infections out of our respiratory tract. And then I'll be focusing on some specific microbes and diseases. Microbes will include streptococcus, tuberculosis, and histoplasma. And then I'll discuss diseases, including bacterial pneumonia, ear infections, cold, and the flu. The respiratory system is broken into 2 parts, the upper respiratory system and the lower respiratory system. The upper respiratory system includes the nose and the mouth. These are 2 great openings for microbes to enter into the body. It also includes the pharynx and the ulva, which which prevent microbes from getting into the lower respiratory system. The lower respiratory system includes everything from the epiglottis down, and very importantly includes the lungs. When we talk about the pneumonia infections, that will be a particularly important part to discuss. The upper respiratory system is covered with mucus, along with serous fluid that forms the airway. This protects the airways from microbes that would otherwise get into the lower respiratory system. 95% of mucus is water, and the remaining 5% is made up of proteins, carbohydrates, salts, etc. The upper respiratory system has a lot of normal microbiota. We've talked about normal microbiota in previous sections. The microbiota of the mouth is very different from the microbiota of the nose, which is very different from the microbiota in the pharynx, etc. So each location in the upper respiratory system has a different type of microbiota, which will be important for keeping microbes out. The lower respiratory system, including the lungs, does not have a lot of normal flora. So samples that are taken from the lungs should be sterile. If we find microbes in the lungs, that's usually a good indication that there is an infection present in the lower respiratory system. The microbiota of the upper respiratory system includes the diphtheroids, Haemophilus, Staphylococcus, and Streptococcus. You should recognize Staphylococcus and Streptococcus and Haemophilus at this point as being causes of diseases. Staphylococcus and Streptococcus have been described in both the lectures that we've discussed so far. Haemophilus influenza was discussed in a chapter on the nervous system. These microbes may also be found in the pharynx. Now, as I said, the mucus is a great way to keep microbes out of the lower respiratory system. In the upper respiratory tract, mucus actually moves up the pharynx. So here we have the pharynx. We have a number of cells that line the pharynx that have a lot of cilia. These cilia move mucus up away from the lower respiratory tract. These are goblet cells or mucus cells that secrete mucus into this area. This movement prevents microbes from getting down into the lower respiratory tract and are an important part of the body's defenses against microbes. I wanted to give you a closer look at what the trachea looks like. So here we've taken a cross-section of the trachea, and you can see that in the esophagus, the mucosa is folded. In the trachea, you have a trachea muscle that helps provide movement, and then we have the mucosa and the submucosa. Submucosa just refers to the area that's below the mucosa. If you take a close-up of the ciliated cells that line the mucosa, you can see that they actually look like hair. And the purpose of this is to move mucus up and away from the lower respiratory tract. This particular section in this scanning electron microscope image of the lung trachea epithelium shows both ciliated, that's these cells, and non-ciliated cells in the epithelium. Now, the lower respiratory tract includes alveoli and the bronchial tubes. The bronchial tubes empty into the alveoli. The alveoli are the sacs, the air sacs, that provide oxygen to the blood. Remember, in our last lecture, we talked about oxygenated blood that returns from the lungs, that's this blood, and oxygen poor blood that goes into the lungs. So blood comes into the lungs, and these oxygen poor capillaries the blood becomes oxygenated thanks to the surface area of these alveoli, and then the oxygenated blood returns back to the heart to be pushed, to be pumped around the rest of the body. These particular sections that I'm showing are parts of the lung. This also shows that, this particular figure also shows that macrophages are present in these alveoli, and these are important defenses in the lungs. The lungs should be fairly sterile. These macrophages, the role of these macrophages is to test this area to determine whether or not an infection is present, and if it is present, then to stimulate the immune system to fight off the infection. And the capillaries shown here are just to show that this is a blood-rich area of the lung. In addition to these alveolar macrophages, the lungs have a large amount of IgA. This is a secreted antibody. You should recognize this particular figure from our lecture on the secondary immune system. Here we have two antibodies that are joined together in the constant region. These two variable regions are available to bind to antigens. I'll give you a second just to think about which part of the adaptive immune response this is and what type of cell would secrete these antibodies. So this is part of the secondary immune response, and B cells would secrete antibodies, including these IgA antibodies. Macrophages are part of the innate immune response. So we're going to cover several diseases today. We'll start with Streptococcus. Many of you will be familiar with Streptococcus. This is the bacteria that causes a strep infection in the back of the throat. Group A, Streptococcus, produces a number of virulence factors that enable this bacteria to both attach and cause damage to the host. Here we show streptococcal pharyngitis. That's just swelling. Itis refers to the swelling of the pharyngeal tube, the back of the tube that goes from the mouth down to the lungs. It's often characterized by these white patches in the back of the throat. Group A Streptococcus infections are often accompanied by a loss of voice or hoarseness, and I wanted to show why that happens. So here we have a normal larynx. The vocal cords are present and open and are able to vibrate when air is pushed past them, but an inflamed larynx, it's not quite as open, is not open as far, and this opening does not permit air to go past it to be able to vocalize. And so you have a hoarse voice, or you can lose your voice altogether. And this larynx is located here. In streptococcal bronchitis, Streptococcus gets past the throat and past the pharyngeal tube down into the bronchial tubes. Bronchitis refers to the fact that this is swelling, itis again, of the bronchial tubes, bronchitis. So here we have a normal tube that allows a lot of air to come into the lungs, into those alveoli, to permit exchange of oxygen into the blood. But when these bronchial tubes are swollen, air is not able to get in through these lungs, through these bronchial tubes down into the alveoli, and so the airway becomes obstructed, making it harder for a person to breathe or to exchange oxygen into the blood. Group A Streptococcus infections will typically be characterized by a high fever, 38.3 degrees Celsius or 101 degrees Fahrenheit, headache, body ache, nausea, vomiting, and swollen glands. Occasionally, the group A Streptococcus infections will be accompanied by what is called strawberry tongue. So here we can see a tongue that's very red and has white bumps on it and resembles a strawberry. In addition, occasionally, very rarely, this group A Streptococcus may cause scarlet fever, which includes a red rash with a sandpaper feel. So it's a raised rash. This is very rare. In this particular case, the bacteria is producing a erythrogenic toxin, and that is what produces the rash. This erythrogenic toxin targets the red blood cells. That's where the urethra comes from. If a rash is going to appear, it typically starts 1 to 7 days after the illness begins, starts around the neck and the underarm and the groin, and then spreads from there. The skin may peel as the rash subsides. Group A Streptococcus has a number of virulence factors that cause these symptoms that we just described. It has, again, I wanted to remind you that this is a gram-positive bacteria that forms these nice chains. So this is what you would look for under a gram stain. These chains of cocci have adhesion and invasion molecules that allow the bacteria to adhere to epithelial cells. In addition, it has M protein that inhibits complement component C3b. If you remember from our innate immune response lectures, this complement typically, the C3b, typically would initiate a cascade that would lead to inflammation and recruitment of new cells, immune cells, to the site of the infection and killing of the bacteria. But because this complement component is inhibited, this bacteria is able to evade the inflammatory response. Some of these other factors you may recognize from our lecture on skin infections: hyaluronic acid, capsule, streptokinases, C5a peptidase, pyrogenic toxin, and streptolysins. As you go through this list in your notes, I want you to think about what each of these does. What do streptolysins actually lyse? It has lysine in the name. What is it lysing? What does the pyrogenic toxin lead to? Treatment for a group A Streptococcus infection includes oral penicillin or erythromycin. We're pretty lucky at this point that group A Streptococcus has not developed the multi-drug resistance that Staphylococcus has, and so we are able to treat many of these infections with penicillin. Streptokinase is a enzyme that Streptococcus produces. We didn't talk about it much when we were discussing Streptococcus infections of the skin, and so I just wanted to discuss what streptokinase does here. So during a Streptococcus pyogenes infection, the bacteria activates the immune system. The immune system then produces fibrinogen and fibrin. This fibrin is a string of proteins that typically would bind the bacteria and prevent it from spreading. Streptococcus produces streptokinase, which then breaks apart these fibrins and degrades the clot so that these bacteria are not bound by this fibrin. And now the bacteria is free to disseminate throughout the body. What does that actually look like? This is a nice illustration showing those fibrin proteins binding red blood cells. In this case, it would normally bind bacteria. And when these fibers are broken apart by streptokinase, you can see that these red blood cells are able to disseminate. Now, in this particular chapter, I have a number of questions for you to answer. I'm going to post the questions on Blackboard so that you can answer them at your leisure, but I just wanted to present them here. Which of the following is not used by group A streptococci to survive in the body? Is it M protein, C5a peptidase, mycolic acids, or streptokinases? And as you go through this question, when you're looking up the answers, when you're figuring out what the response should be, I want you to think about what each of these virulence factors actually does. What is M protein actually used for? Where do mycolic acids come from? What particular bacteria uses C5a peptidase? So that was Streptococcus, and those are infections that are found in the pharynx and sometimes move down, disseminate throughout the body. I wanted to focus next on otitis media and rhinosinusitis. So these are infections of the ear and the upper respiratory system. I like this little figure. It's a cartoon from XKCD, and it's just showing how you feel, which is the worst, bad, or fine, and where in an infection you are. And it's just a fun little cartoon. Here's where you need sympathy. This is where you actually get sympathy. And I like this in part, even tying this into our last section, because of course for streptococcus, for streptococci, you had the swelling of the pharynx, and that was somewhere in here where you sound really bad and you get your sympathy. For a viral infection, this actually is where you're recovering from that viral infection, but you still sound bad. Okay, so what are these infections? This is otitis media. Otitis media is an infection of the ear canal. So here we have the external ear canal. Here's the outside of the ear, the inside of the ear. Here we have the tympanic membrane, and this is the membrane that receives vibrations that from the outside. These vibrations are converted into vibrations that this little tiny bone here converts into messages that are sent to the brain to tell you what you just heard. This is the middle ear. The middle ear is connected to the pharynx by this auditory tube, the Eustachian tube. This Eustachian tube can occasionally become blocked. So here we have the eardrum again. The ear is on the outside. Here's that external ear canal. Here's the eardrum, which is the same as this one. And the Eustachian tube normally is open so that you have balanced air pressure between this middle ear and you have balanced air pressure between the middle ear and the external ear canal. This only works well if the Eustachian tube is open and you can get normal drainage of fluid. But if this becomes blocked, you get fluid trapped in this middle ear, and that results in an imbalance of air pressure, and this can result in an inability to hear or actually losing balance. One of the things I wanted to point out here is how close this middle ear is to the pharynx. So here we have the pharynx, here's the middle ear. This Eustachian tube, if it becomes blocked, can become blocked because infections can move from the pharynx here into the middle ear and into this Eustachian tube. And of course, this pharynx leads up to the nose and sinuses and connects to the throat. Infants tend to get more ear infections, that's what otitis media is, tend to get more ear infections than adults. And I wanted to just highlight why that is. So the Eustachian tube in infants is almost horizontal in that the Eustachian tube goes from the middle ear here to the pharynx, but it's almost horizontal. And this means that bacteria can move from the pharynx into this middle ear and lead to swelling in this Eustachian tube fairly easily, whereas in adults, this Eustachian tube is at an angle, and that allows some ample drainage from this middle ear into the pharynx. So what causes inflammation? That's where the itis comes from. What causes inflammation of that middle ear? Some common causes include the bacteria Streptococcus pneumonia, which you should be very familiar with by now, Staphylococcus aureus, Haemophilus influenza, Moraxella catarrhalis, Streptococcus pyogenes, and different viruses. If the cause is bacterial, you can treat with broad-spectrum antibiotics. And the reason that broad-spectrum antibiotics are used is because it's very hard to take a sample of this middle ear, right here, to determine what type of microbe is causing inflammation or causing fluid to build up in the middle ear. It's hard to take a sample from there because you'd have to get through this membrane, and you don't want to pierce the membrane. That will affect hearing. So it's very difficult to actually sample the middle ear to figure out what type of microbe is causing the disease. And so that's why you treat with broad spectrum. But I did want to point out that viruses cause most of the ear infections in infants, and so that's why some physicians are moving away from treating ear infections with antibiotics. Instead of treating kids with antibiotics, if there are kids that have frequent ear infections, we move more towards prevention rather than treatment. In this particular case, you can insert tubes through the eardrum to keep this eustachian tube open, and you can immunize against many of the different types of microbes that cause this inflammation. So those are ear infections. Ear infections are often accompanied by colds, or colds may lead to an ear infection. I like this little cartoon because it's just kind of a reminder of the common misconception that viruses always come with cold season. We're not really sure why cold seasons like fall and winter tend to lead to increases in the common cold, but there are many hypotheses out there. One of the things that we do know is that there are over 200 different subtypes of viruses that can cause the common cold. This makes it very difficult to make something like a vaccine against the common cold because there are so many viruses that can cause it. These include rhinoviruses and coronaviruses and some others. Those are the two main types of viruses. Viruses tend to prefer 33 degrees Celsius, which is the same temperature as the nasal cavity. So here we have somebody who might have been infected with a virus in her nasal cavity, which is at a lower temperature than the rest of the body. This virus prefers this temperature, which is why it tends to hang out in the sinuses at the surface of the body rather than going deeper. The higher temperature and lower pH of the lower respiratory tract can inhibit or destroy these viruses. During the height of infection, there can be up to 100,000 virions per milliliter of nasal mucus at the height of a cold. And so this is just to illustrate just how far a spray of mucus can go when somebody sneezes. And this is just a close-up of one of the viruses that could possibly be in here. And just a reminder, there could be 100,000 of these per mil of fluid coming out of here during a sneeze. Sneezing is in part due to infected cells that are sloughing off as they're dying. So remember, these are viruses. They're actually destroying the cells as they replicate. And so as the infected cells slough off as they die, this stimulates the inflammatory response in the nerve cells. There are a couple of videos. There's a fabulous video on the science of the dispersal of droplets in a sneeze for those of you who are interested. And there's a fun quick read on the immune response to cold viruses here at Beatrice Biologists. Now colds often also, in addition to sneezing, come with a difficulty breathing. And this, again, is due to bronchiolitis, as we saw earlier, when the airway becomes obstructed from swelling of the bronchial walls. So the cold virus, when it gets down into the lower respiratory system, remember this is the lower respiratory system, can lead to swelling of these bronchial tubes. These bronchial tubes empty into the alveoli, which again, oxygen is exchanged with blood. But in order to get get oxygen down into these alveoli, you need bronchial tubes that are open. So when these become swollen, it makes it difficult to breathe. Now, cold infection is sometimes mistaken for a flu infection. So I wanted to cover these two different types of respiratory infections. The cold virus is different. Viruses that cause the cold are different than viruses that cause the flu. The flu is caused by influenza viruses. So here we're showing influenza type A virus. This is different than the viruses that cause the cold. There are several symptoms that characterize the flu to separate it from the cold, from a common cold. So for example, in patients that have the flu, a fever will be really high compared to a cold in which patients rarely have a fever. Headaches are really prominent with the flu, but they're rare with colds, although if you have a sinus infection that accompanies the cold, you may have a headache in the sinuses. General aches and pains are usually severe with the flu, whereas they're much slighter with the cold. And you can go through here and look at the different symptoms that are, all the symptoms that are different for the flu versus the cold. One of the things that I wanted to point out here were the complications. So the complications for the flu can be quite traumatic, including this bronchitis, again, inflammation of the bronchial tubes, and pneumonia, which can be life-threatening. This pneumonia can take weeks to recover from, or months. Whereas the complications from the cold are relatively minor, sinus congestions or earaches. And of course, for the flu, we have an annual vaccination, but as I said, there are so many different viruses that cause the cold that there is no prevention for a cold in terms of a vaccination. And then there are some antiviral drugs that can lessen the symptoms of a flu if given within a day or two of the onset of symptoms. But for the cold, there's only temporary relief of symptoms. Now, in our lecture on immunizations, we talked quite a bit about making vaccines against the flu. So I didn't want to go too into depth about vaccines, but I did want to remind you that the flu viruses have a couple of different proteins that are on the surface of the virus. Here we are showing HA, which is the hemagglutinin protein, and then here are the neuraminidase proteins. And there are several neuramidases and several HA proteins that can be found on the surface of influenza viruses. And these determine whether or not an antibody is going to be able to bind to the virus to neutralize it. These are encoded in these nucleic acids that are found in the virus. For influenza, influenza has several segments of RNA that encode all the proteins that make up the virus and all the enzymes that are needed to replicate. Now we can make a vaccine against these neuramidases and these hemagglutinins, but unfortunately we can't include every hemagglutinin or every neuraminidase enzyme in a single vaccine. And so we make vaccines against specific HA or NA proteins. This would be fine if the virus only expressed one or two types of HA or NA, but unfortunately they have several different types of these. And a virus can undergo antigenic drift and antigenic shift by exchanging pieces of nucleic acid with other viruses if they infect the same cell. So I wanted to cover the difference between antigenic drift and antigenic shift. First, we'll look at antigenic drift. When an influenza virus enters into a host cell, the nucleic acids are released from the capsid and enter into the nucleus. In antigenic drift, these nucleic acids gain mutations that change these proteins a small amount. Then these mutated viruses now are now released from the cell. These are only slightly different from the virus that entered into the cell because they only have small mutations in their nucleic acid. Now this is different than antigenic shift. For antigenic shift, two different viruses enter into the same host cell. While they are in the host cell, they exchange nucleic acids. So for example, one of the segments from this may enter into, may be mixed up with one of the segments from this virus. Now these shuffled segments, in which entire pieces of nucleic acid have been exchanged, results in the release of a virus that looks nothing like virus 1 and virus 2. During cases of antigenic shift, we see big outbreaks of influenza virus. So for example, in a typical year, you would see a typical number of cases, and this is due to the fact that people are not able to make an immune system, an immune response against a virus that they haven't seen before. But there's some protection against the influenza virus if there are only small changes in these HA and NA and M molecules, these HA molecules and these NA molecules. If there are small changes, then we may have an immune system that's able to fight off the worst of the symptoms. But if our body comes in contact with a combination of HA and NA molecules that it has not seen before, then we are much more likely to get to have a full flu experience, in which case you'll see large outbreaks. So in this particular case, in this year, in these 2 years, at year 10 and year 20, there was an antigenic shift in which large pieces of nucleic acid were exchanged and a completely new virus emerged from this cell, one that the body had not seen before because it's a new combination of HA and NA molecules or other virulence or other antigens. That's typically HA or NA. So that's the flu. That's antigenic drift versus antigenic shift. Now we're going to move on to bacterial pneumonia. So now we're going to start focusing in on infections of the lower respiratory tract. Here again is an alveoli. This is what it should look like in a healthy patient. Nice big airways for lots of air exchange, lots of oxygen exchange from the air into red blood cells. In pneumonia, these alveolar wells are thickened by edema, that's swelling. Thickened by edema, which is swelling and fluid buildup. And in fact, here you can see there's fluid and blood cells in the alveoli. There should not be any blood cells in the alveoli, but in really bad cases of pneumonia, you will see blood there. In pneumococcal pneumonia, the symptoms start with some pretty severe, are accompanied by pretty severe symptoms, including fever, chills, congestion, cough, and chest pain. This congestion, cough, and chest pain is due to the presence of microbes in the alveoli. This results in short, rapid breathing as the lung is not able to fill up completely with air. Blood enters into the lungs, causing rust-colored sputum. Remember that these alveoli are tightly surrounded by blood vessels so that you can get nice exchange of oxygen at that air-blood interface. Streptococcus pneumonia causes fluid to build up in the lungs, and so here we have an X-ray of a patient who has the Streptococcus infection, Streptococcus pneumonia infection. And you can see the lungs should be nice and clear, but instead we see a whole lot of cloudiness down here, and that's due to fluid buildup. Virulence factors for Streptococcus have been covered extensively, but just to remind you, it does have adhesins on the surface of the bacteria that allow it to adhere to the cells in the alveoli. Pneumolysin is able to lyse cells in the lower respiratory tract, and then that polysaccharide capsule. And I want you to take a minute to remember what the polysaccharide capsule does. It helps evade the immune system. I want you to take a minute to remember which cells should be present in, or which immune factors should be present in the alveola. So antibody, you should have thought of antibody IgA. that is associated with mucus should be found in the alveola, and then those phagocytes, the macrophages, alveolar macrophages, should be present. And if the microbe has a capsule, it may be able to evade phagocytosis. Infection typically occurs by inhalation of the bacteria. So it enters into the lungs through inhalation. The bacterial replication causes damage to the lungs. IgA is destroyed by secretion of pneumococcal IgA protease. And pneumococcal pneumonia accounts for the most cases of bacterial pneumonia. So of all the different types of pneumonia, bacterial pneumonia that a patient can have, it's most frequently Streptococcus pneumonia. Diagnosis is by looking for these diplococci in sputum smears. So having the patient cough up sputum from deep in the lungs and then looking for these diplococci. Now, one important thing to remember is that there are a ton of normal flora in the mouth. There shouldn't be very many microbes deep down in the lungs, but there are a lot of microbes in the mouth. So if a patient spits up spit rather than sputum, you would expect to see many different types of microbes, but what you're really looking for is sputum that comes from deep down in the lungs. And if you see microbes in that deep sputum sample that comes from the lungs, then you know you have an infection. Treatment is with penicillin, and there is a vaccine to prevent infections. There are now some strains of Streptococcus pneumonia that are penicillin resistant. Another microbe that can cause pneumonia is Klebsiella. Klebsiella pneumonia is often characterized by, again, that thick sputum and infection deep in the alveola, but it's also characterized by a capsule that can be visualized in a sample. So here we have Klebsiella pneumonia, and if you zoom in close, you can see that it has a thick capsule around it. That capsule is so thick that when you take a sample of Klebsiella and you grow it on a blood agar plate, and then you touch a toothpick to the colony of Klebsiella, you'll see that mucus pull away from the colony and cling to the toothpick. Diagnosis is immunocompromised individuals are at greatest risk of infection from a Klebsiella pneumonia infection. In healthy patients, we're able to fight this infection. Our immune system is able to clear this bacteria out, but in immunocompromised patients, their immune system is compromised. They're not able to clear out the infection. Diagnosis is by identifying Klebsiella in sputum samples. Again, you want that deep sputum sample that comes from deep in the lungs. And we are able to treat Klebsiella with antimicrobials. Prevention involves good aseptic technique by healthcare workers, and that's a really good indication that this infection is preventable is actually spread by healthcare workers. And indeed, you see here, pneumonia symptoms include a thick bloody sputum and recurrent chills, and this is a hospital-acquired infection or a nosocomial infection. The death rate for Klebsiella infections is really high, up to 50% even with treatment. In part, this is because as the bacteria die, they release LPS, that lipopolysaccharide, which destroys the alveolar cells and leads to bacteremia. So this infection may start in the lungs, but in an immunocompromised patient, LPS is released from the bacteria as it is being killed off by the immune system or by drugs, and releases that LPS. The LPS helps stimulate an over-inflammatory response, a large inflammatory response in the alveolar areas, and so this leads to a weakening, a thinning of the capillary walls, and that leads to spread of this bacteria through the body. And if you remember from our last lecture, this can lead to overall system failure of other organs as the bacteria spreads through the body in the blood. There is no vaccine against Klebsiella pneumonia at this time. So those are two different types of causes of pneumonia. Another bacteria that can cause respiratory infections is Legionella. Legionella pneumophila can cause Legionnaire's disease. This was originally discovered by if you remember a couple of lectures ago, I discussed Legionnaire's disease, and the discovery of Legionnaire's disease was due to an outbreak of a pneumonia-like infection from elderly men who had attended a Legionnaire's convention. It turns out that Legionella outbreaks have occurred at other times as well. A most recent one that I found was a Legionnosis outbreak in New York City in 2015. And one of the reasons that these outbreaks continue to occur is because we've built this really great environment for Legionella. Legionella does really well in cooling towers, and as we've installed cooling towers in our buildings to cool buildings down, we've made a great area for Legionella to replicate in. And this is just showing the different ways to keep Legionella at bay when you have a water tower, including regularly checking the cooler tower for evidence of biofouling. And that's really just looking for slime layers in which this Legionella will be able to replicate. So how is it spreading in water coolers? Why is it able to use water coolers to spread? Here we have a nice diagram of a water supply. This water supply supplies water to a water tower. As the water cools in this water tower, it creates these aerosols, and humans or hosts here can become infected from this aerosol. And the reason they can get infected from this aerosol is because this aerosol contains amoeba that have Legionella pneumophila within the amoeba. So here we have an amoeba, and here we have bacteria. Normally, an amoeba can destroy the bacteria just like a macrophage can. And in fact, if you think of an amoeba that phagocytizes microbes, that's an awful lot like a macrophage that phagocytizes microbes. And so this bacteria has learned how to, has evolved to be able to survive this phagolysosome. So remember the phagocyte, in this case an amoeba, pulls in the bacteria and creates a phagosome that binds to a lysosome, and typically that would kill the microbe. Legionella has figured out how to survive in the vesicle as it's being pulled in. So instead of being killed, it replicates and then lyses out of the amoeba. And this is just illustrating that an amoeba is an awful lot like a macrophage, and that this particular bacteria is able to use the same system to be able to survive in an amoeba, which forms the slime layer, and in a macrophage. And this is also showing that this bacteria can form biofilms. And these are some of the effector proteins and virulence factors of pneumophilia, and this is the life cycle of Legionella pneumophila. So here we have a bacteria that has a type 4 secretion system. It releases proteins from this type 4 secretion system. So the secretion system is kind of like a tube that goes from this bacteria into the cytosol of this host. It pumps proteins, the bacteria pumps proteins through this tube, this type 4 secretion system, and manipulates, changes the ability of the host to kill this bacteria in a phagolysosome. So here you can see that within 5 minutes of entering into the cell, being phagocytized by a macrophage, this bacteria is able to not only survive, but build a protective little wall around itself and then replicate within 4 to 6 hours. And 14 hours after the infection, these bacteria then are released from the cell and they go on to infect neighboring cells. Now, we are able to treat Legionella infections with quinolones or azithromycin. This bacteria is able to survive really high temperatures, so it's able to survive in heating and cooling systems and survive in these vacuoles. Okay, so I have a question for you. How do people acquire Legionnaire's disease? Is it through person-to-person contact, inhaling vesicles and water droplets, puncture wounds, or fecal-oral routes? Okay, so now we're going to turn to tuberculosis. Tuberculosis is a disease that Alaskans have had to deal with for quite a while. Here we have a picture of kids that were housed in a sanatorium, also called a sanitarium, in Portland, Oregon, in the somewhere in the 1920s to the 1940s. As you can imagine, these kids were separated from their families. They were housed here for long periods of time, 6 months, a year, 2 years occasionally, and this resulted in kids who were separated from their family during critical times of development. And these kids often were also not educated in the sanatoriums or the sanitariums. This relationship with tuberculosis in Alaska continues today. Our rate dropped in 2016, but we still had the second highest rate of tuberculosis in the nation. We have up to 3 times the national average for the number of cases per 100,000 people in Alaska. This is second only behind Hawaii. So this is quite a disease that Alaska has to deal with. Worldwide, approximately 9 million new cases of tuberculosis are diagnosed each year. So this is a problem not just here in the United States and in Alaska, but this is a worldwide problem. This is the leading microbial disease killer in the world, and it's complicated by the fact that the bacteria that causes tuberculosis is able to not just survive in the lungs, but also acquire antibiotic resistance during an infection. So here we have the disease progression of tuberculosis. The bacteria that causes tuberculosis is Mycobacterium, also called Mycobacterium tuberculosis or MTB. This bacteria infects a person through the respiratory route via inhalation of respiratory droplets from an infected individual. The bacteria goes through the trachea down into the deep lungs, down into the lungs, into the alveoli. In the alveoli, it replicates. It comes in contact with the macrophage, but it's able, and here's a very nice picture of a macrophage phagocytizing some mycobacterium. The macrophage phagocytizes mycobacteria, but they are not able to break them down because the bacteria inhibits fusion of the lysosome to endocytic vesicles. And so these bacteria that would normally be killed by the alveolar macrophage are now able to survive within the macrophage and start replicating. So the bacteria replicate freely within the macrophage, eventually killing the phagocytes, the macrophages. The bacteria are then released from the dead macrophage to be phagocytized by a new macrophage in which it replicates and begins the cycle anew. This cord factor that tuberculosis, Mycobacterium tuberculosis, creates, this cord factor is able to protect TB from killing macrophages, killing by macrophages. This cord factor also helps create caseating granulomas. These are large groups of cells in which infected macrophages are in the center of these granulomas, and then they're surrounded by T cells, and they're surrounded by T cells, and this tubercle forms over a 2 to 3 month period. This is an artist drawing, but here's what it actually looks like in the lung tissue. Other cells deposit collagen fibers enclosing the infected macrophages and lung within the tubercle, and then the infected cells in the center die, releasing more of the bacteria and producing caseous necrosis. So in this particular case now, we have tissue that is dying, and that releases, and that leads to a cheese-like consistency due to protein and fat that are released from the dying cells. At this point, the body's immune system isn't actually able to detect the bacteria that are in the very center of this caseous necrosis. Here we show a lung lesion caused by tuberculosis. This tissue should be healthy and pink and full of air, and instead you can see there are these big lesions within the lung, these huge holes in the lungs, which these alveoli have just been destroyed by the bacteria. And this is where the destruction actually occurs as this tubercle is ruptured and mycobacteria are released from this tubercle. At this point, there's a secondary and reactivated infection, and in this happens in about 10% of patients, and it's typically found in patients who have immune systems that are weakened by disease, poor nutrition, drug or alcohol abuse, or by other factors. From our lecture on hypersensitivities, you should remember that the tuberculin test is a type 4 hypersensitivity. So this is a delayed reaction involving T cells. In this particular case, antigens from Mycobacterium tuberculosis bacteria are injected underneath the skin, and the doctor looks for inflammation, redness, and inflammation. If the reaction is negative, the patient is actually retested later to make sure that the patient truly is negative, because if they have been recently infected with tuberculosis, the T cells may not have built up an immune response that's big enough to be able to be detected by the tuberculin sensitivities test, the PPD test. In addition, we can also do a sputum test. So again, the patient needs to cough up some sputum from deep in the lungs, not spit from the mouth, because the spit in the mouth would only contain normal microbiota. You want the sputum from deep down in the lungs, and then that sputum can undergo an acid-fast stain, and these bacteria stain pink in an acid-fast stain. There are many different drugs against tuberculosis. This is just showing the different targets of antibiotics that are used to kill tuberculosis. Unfortunately, because tuberculosis replicates so slowly, it can acquire resistance to these antibiotics, many of which target replicating cells. So because the bacteria is able to replicate very slowly, they can gain mutations and avoid killing by these antimicrobials. Because of the slow replication of Mycobacterium tuberculosis, treatment is typically up to 9 months, and due to the ability of this bacteria to gain antibiotic resistance, treatment typically includes not 1 or 2, but typically 3 different types of antibiotics. Multi-drug resistant tuberculosis may be treated with up to 6 different types of drugs. So a combination of 6 of these drugs to be able to treat multi-drug resistant infections. Okay, question for you. All of the following are true for Mycobacterium tuberculosis and tuberculosis except A, extensive drug-resistant strains have emerged, B, tuberculosis is the leading killer in the world, C, virulent strains produce cord factor, or D, the bacteria are often lysed upon phagocytosis. So this question again will be presented on Blackboard and you'll be able to answer it at your leisure, but before Friday, please. Okay, so now we're going to move away from bacterial infections and viral infections and into fungal infections. These are mycoses of the lower respiratory system. Mycoses refers to the fact that these are fungal infections, and these are fungal infections of the lower respiratory system. Now, this is where it becomes really important to get an accurate patient history. And this is because different types of fungal infections are associated with different regions of the world. So, for example, if you had a patient who had been along the Mississippi Delta here or along the Mississippi River, you might first consider blastomycoses. But if the patient had been to Africa, you would first consider histoplasmosis, or if they had been to the area here between North America and South America, you would first consider coccidiomycosis. So patient history is really important in diagnosing different types of fungal infections. We're going to start with histoplasmosis. Histoplasmosis is an infection that is commonly, histoplasmosis is an infection caused by a yeast that's commonly found in the environment. So here we have an environmental form, and you can see that this Histoplasma capsulatum is in a form that includes hyphae, and these hyphae have these balls of spores that release spores into the environment. And here we have these spores that are floating around in the air. These spores are so light that they can be dispersed through the air in relatively long distances. And these are now inhaled by a host. As these spores enter into the deep, warm tissues of the lungs, the warm temperature induces this fungus to these spores to convert into a new form. And this new form is a budding yeast. And you can see that this budding yeast here also has a capsule. The yeast are phagocytized by immune cells and then transported to regional lymph nodes. So here we have our lymph nodes, and remember that lymph nodes are places where phagocytes typically present antigens to B and T cells. So it makes sense that these fungi that are able to survive within a phagocyte are then moved to the lymph nodes. Once they are phagocytized and circulating in the lymph, they are now able to be dispersed throughout the body, and they are often found in they often circulate back into the lungs of the host. There are specific regions that are endemic for histoplasmosis, including these regions here in the United States. Temperature triggers spores to convert into yeast. Most patients who inhale these spores recover very quickly from an infection, but immunocompromised patients, these yeast get into macrophages, and then these spores are distributed. These yeasts, are distributed throughout the circulatory and lymphatic systems. Symptoms may look like tuberculosis, so this is where it becomes really important to get a case history to try to differentiate between tuberculosis and histoplasmosis. And this is also a good reason for getting an accurate sputum sample. So when you think about what histoplasmosis would look like as opposed to mycobacterium, and what stain you would use to differentiate between mycobacterium and histoplasmosis. So hopefully, when you thought about that, you thought about the acid-fast stain that would help you identify mycobacterium in sputum. So in histoplasmosis, as I said, these yeasts can circulate in macrophages throughout the rest of the body. And so in immunocompromised patients, again, not healthy patients, because healthy patients, the immune system will be able to overcome this infection. But in immunocompromised patients, like AIDS patients or the elderly, Histoplasma capsulatum is distributed throughout the body, and this can lead to an enlarged spleen and liver and often death. So this is what Histoplasma capsulatum looks like in a macrophage, and you can see that this macrophage is just littered with these little tiny yeasts that are able to replicate within the macrophage. Disseminated histoplasmosis can cause a rash throughout the body. This is disseminated histoplasmosis in an AIDS patient, and it can also form many small nodules in the lung. So contrast this to the Klebsiella infection that we saw earlier, where the infection was mostly in the lower lobes of the lung. Here in histoplasmosis, you can see that there are calcified nodules all over a patient, all over this patient's lungs. Now, it's important to note that these are in a healed patient, so there can be long-term effects, although this is an asymptomatic patient. So even though this patient was able to control the infection and heal and get rid of the yeast, there are long-term effects in which this asymptomatic patient has lesions throughout the lungs. So histoplasma is also associated with caves, in part because it can be shed in the feces of bats. So attics are one place that histoplasma can be found, and it can also be found in caves. And this is one of the reasons I just kind of like this. This is, to end on a lighter note, this is one of the reasons that people have associated mummies' tombs with curses, and that is because people who would enter into these mummy tombs where there are an awful lot of bats or other animals shedding histoplasma, histoplasma capsulatum, would become sick after leaving the tomb. Acute histoplasmosis is the result of heavy exposure and inhalation. So typically, if you have bats in your attic, you may get a light exposure, but if you're in a cave that has this many bats, and recognize that each one of these little white blobs is eyes from a bat, so there's an awful lot of bats here. If you inhale a lot of histoplasma, you can develop acute histoplasmosis as a result of heavy exposure and inhalation. The result can be severe and overwhelming illness because you are getting so many spores in your lungs at once, and these spores are all replicating. Instead of getting a mild cough or pneumonia-like symptoms, you get overwhelming illness, acute dyspnea, high fever, and fatigue, and it's very dramatic. And this is one of the reasons that people thought that they had been cursed when they came out of these mummy tombs, where they, instead of being cursed, they had actually had acute histoplasmosis. Okay, those are all the diseases that we're going to cover for today. Remember that you do have to know about the other diseases in your book. Yeah, have a great day. And don't forget to answer the questions that will be posted on Blackboard shortly if they're not posted already.